is Dr. Linda Titus, the Associate Director of the Hood Center for Children and Families. I'm right, yes?
Yes.
Oh, good. I've made mistakes before. Dr. Titus is a Principal Investigator of the National Cancer Institute's DES Combined Cohort Follow-Up Study, which Carrie was referring to, which assesses the impact of this prenatal exposure on adult health outcomes, and leads the NCI-sponsored multi-center study of DES outcomes in the children of women who are exposed prenatally to this drug. Right?
Very nice, thank you.
Thank you.
So I'm going to hold my laptop on my lap. Where do you want mine? Here?
That would be great.
Okay, so that I don't have to turn around and see my slides.
Can you help there?
I'm just going to make sure this doesn't tip over. It's perfect. And I'm going to turn the lights off so that you can see.
Okay. And I think we can skip directly to the fourth slide because we've got a bit of redundancy here. There you go. So I'm going to repeat a few things that Carrie already said, which is that DES was given to women for use in pregnancy, and it was meant to prevent pregnancy complications, particularly miscarriage. We don't know how many women were exposed. There are estimates, but we really don't know. The estimates range from 0.1% in some medical centers to 7% at the Mayo Clinic, and we estimate that perhaps 2 million, Carrie said 5, and that's possible, offspring are exposed to in utero, and I think you were also including the moms.
Yes.
And as we also mentioned earlier, it was the Smith and Smith regimen that was quite popular with very high cumulative doses. This dose, I believe, corresponds to approximately 300 times the amount of estrogen that would be given to a woman in 1 year to treat postmenopausal symptoms. And these women were pregnant. So it gives you an idea of how tremendously powerful this exposure was. And I should also say that DES as a synthetic non-steroidal estrogen was much more powerful than estradiol, the natural estrogen. Was it safe? Well, no, it wasn't. And there were several clinical trials that looked at it, and as Carrie mentioned, they did not do the best possible analysis of the data. The data showed later when reanalyzed that the DES was actually detrimental to pregnancy outcome, not at all helpful. One of the things that's fascinating about DES is that in the context of this drug, the mouse model mimics the human experience very well. That doesn't always happen, and I'm sure some of you at some point, and I know I'm guilty of this, have said, but that's a mouse. What possible relevance could it have? Well, in the context of DES exposure, the relevance is striking. And as early as 1938, mouse studies showed that female mice who were given DES when pregnant had an increased incidence of breast cancer. And that was later replicated in human studies. The mouse model actually replicated the human finding of the vaginal adenocarcinoma, the clear cell tumor that is the clinical hallmark, really, of DES exposure in the prenatally exposed women. But in that setting, again, the women had the tumor, and the exposure, the link between the exposure and the tumor was shown afterward in the mouse model. But just keep in mind, the mouse model does a really good job of imitating what happens in humans when they're exposed to DES. And this, again, is one of the most striking advertisements that I've ever seen. And it shows that DES rapidly became a drug that was given to women for no particular reason at all, just because they were pregnant. And despite the lack of evidence of efficacy, and despite the fact that initially it was meant to prevent pregnancy, adverse pregnancy outcomes, it soon was adopted at some medical centers as a routine drug for administration. The seminal study, as Carrie mentioned, the one that really blew the roof off the house, so to speak, was this discovery of clear cell adenocarcinoma in young women. And I want to talk a little bit more about that because I think this is an incredibly interesting model for human exposure. The mother that was convinced that this drug she had taken during pregnancy was the reason that her daughter had this tumor hammered two physicians over a fairly lengthy amount of time. She was absolutely on a mission. She was certain that there was a link between the fact that she had taken this drug while pregnant and the fact that her daughter had this very rare tumor. And finally, one of the physicians decided to follow up and investigate it formally, and that led to this very famous case control study that had only 7 or 8 cases of women, young women with tumors. We don't do studies like that. In epidemiology, our studies generally have hundreds, if not thousands, of cases in order to detect an association between an exposure and a disease. But in this particular context, the connection between the exposure and the disease was so powerful that it showed up in a study that we wouldn't even consider doing these days because it's so incredibly small. And I don't know what slide you're on, but I'm on. Good. Okay, so the other thing I wanted to sort of drive home is how miraculous it is really that this connection was uncovered. And it wasn't just the persistence of the mother, although that obviously was the instigator. But I think it probably was very important that the tract that was affected by this exposure was the reproductive tract. And I'm going to guess that a lot of these mothers took the daughter back to the same physician who had prescribed the drug, the gynecologist or obstetrician who had prescribed the drug to begin with. The other thing is that the drug induced this tumor in very young women. I think the youngest case was 9 years old. The risk began to elevate as early as age 12 or 13. So they were unlikely to have moved outside the area where the drug was prescribed, and therefore, again, more likely to go back to the same physician. And finally, what's so remarkable about this connection is that usually this particular tumor is seen in older women, postmenopausal women. So it was striking that it was seen in such young girls, young women and girls. And I want to just impress upon you the possibility that we have environmental exposures out there that have a much longer lag time and that have allowed people to move away from the source point of their exposure, that affect different organ systems so that people go back to different physicians and the same physician is not looking through the same chart as he had for the patient's mother. And finally, if the exposure affects the risk of the disease at an age that the disease is commonly seen, would we even notice? We might see an elevation in incidence, but would we get the connection? Probably not. We might not realize there's any connection at all. Next slide. And this shows you what I was just saying, the age of diagnosis. You can see how young these women were and girls were. It's pretty shocking. I want to talk a little bit about what inspired people like Carrie and the National Institutes of Health to become involved in DES. There were some concerns about sons. There were concerns about urogenital anomalies, which have borne up in later studies. Reduced fertility has not really been supported by all studies, and the question of testicular cancer, increased risk, probably will never be completely answered. Next slide. There are also concerns about the mothers because of the mouse model. And there was concern about increased risk of breast cancer, and some studies did show this. And there was possible increased risk of fatal breast cancer, which was also shown. And I apologize for the incomplete references. Next. At any rate, action groups were very effective in convincing Congress to appropriate money for the study of DES exposure. And if that hadn't happened, we wouldn't know very much about this disease. These diseases. And it's extremely important that we do, because even though DES is no longer given to anyone, anywhere I hope, it is a model for environmental exposure, for pharmaceutical exposure, and certainly for endocrine disrupting chemicals. And it tells us that we need to be really careful about what we take. I think Sue drove that point home very, very well. So the NCI put together the combined cohort study. It has 6 different names. Every time I read a paper of ours, we're not very consistent in how we call it, but it is the DES combined cohort study or follow-up study. And the NCI has funded this study since 1992. We are still funded to pursue this work. And I am one of 5 principal investigators on this study, and I do lead the 3rd generation study. So we have data from the mothers who are the women who were given DES while they were pregnant. We have data from the sons and the daughters who are the children who were exposed prenatally in the womb because the mother had taken DES. And we also have the granddaughters. We have questionnaires over multiple periods of time. We do a search through the National Death Index to identify people who are lost to follow up, people who don't return their questionnaires, to try to figure out what happened to them. And next slide. So one of the first things we did when we organized this study was to look at DES-related outcomes in the mothers, the women who were given this drug while they were pregnant, and we did verify the earlier findings of increased breast cancer incidence and mortality. It's not a huge increase, it's about a 30% increase in risk, but it seems to be quite real. And it holds up even if you control for things like mammographic screening. So I'm quite convinced this is a causal link. Interestingly enough, there's no evidence of a link between other hormonally mediated tumors, particularly endometrial cancer, which surprises me because that's a very hormone-sensitive organ. And as you probably know, the early estrogens that were given out for postmenopausal therapy before progestin was added to the drug resulted in what was virtually an epidemic of endometrial cancer. So that's an organ that's very responsive to estrogen in a bad way. On the next slide, our study also looked at the sons. This is the NCI combined cohort study. And we did see an increased risk of some urogenital anomalies, including undescended testicles. And that one is particularly important because we know that's associated with testicular cancer. So even though we can't nail down the association between prenatal exposure to DES in men with testicular cancer, this is a suggestive finding that supports the suggested association that we see when we directly study cases of testicular cancer and look for DES exposure. Epididymal cysts, urethral stenosis, and any GU anomaly whatsoever are all increased in men who were prenatally exposed. But we don't see an impact on their ability to father children or how many children on average they have fathered, which is good news. So even though they have these anomalies, they seem to be functioning okay in terms of fertility, which of course is not the situation with the daughters, which is one of many reasons we study the daughters more intensely. In the daughters, we confirmed the T-shaped uterus, which is a clinical hallmark of DES exposure. We've seen malformed fallopian tubes, structural anomalies of the cervix, and tissue anomalies of the vagina. Next slide, please. And one of the things that we found is an association between DES, prenatal DES exposure, and high-grade squamous neoplasia, or CIN2+ of the cervix. And this is seen even when we adjust for birth year and cohort and the covariates or confounders that we ordinarily want to control for, and when we adjust for pap smears so that it's not just an effect of increased screening in DES-exposed women, which we might expect. Next
Wait,
slide.
Dr. Tice, I'm sorry. I don't know what high-grade squamous neoplasia of the cervix is. Sorry.
Dysplasia of the cervix. So if you go in and you have a pap smear and it comes back positive, it's showing dysplasia. And there's mild, moderate, and high grade. And high grade is the closest thing to a carcinoma in situ, which could then become an invasive carcinoma of the cervix, a squamous cell carcinoma of the cervix.
Thanks.
Cervical cancer is the disease that was so effectively reduced by the pap smear. And this high-grade squamous neoplasia is the precursor of cervical cancer. So when a woman is diagnosed with that, she is treated fairly aggressively. She's watched for a while because sometimes the HPV virus that's associated with it will abate and nothing will happen. It won't progress, but it can progress to cancer. So DES also appears to be associated with this. This is basically a little table looking at the timing so that you can see that if a woman is exposed prenatally very early in the gestation, that the risk is the highest. One of the things that was of interest to some of the investigators was whether DES exposure was more strongly linked to health outcomes if the woman also had vaginal epithelial changes. And this is one of the things that Dr. Hoover looked at in his recent paper in the New England Journal of Medicine. And the idea is that these vaginal epithelial changes are a marker of dose or sensitivity to the DES exposure. And I won't wade you through this chart, but for sure it looks as though risk is slightly increased for all these outcomes if the woman also has the vaginal epithelial changes, or VEC.
Sorry, what would that be?
It's adenosis. It's in fact, the study that
Or the
It's-
mantle or the hood? Like
no, it's
liver?
actually a tissue
Oh.
anomaly of the vagina
Oh,
itself. Yeah, rather than a structural,
Yeah.
it's more of a tissue anomaly. And when Carrie said the DSAT project, that actually stands for DES, adenosis, because the adenosis, like, again, we're talking about a precursor. The vaginal adenosis that is caused by DES, and that is a causal association, not just a statistical connection, is a precursor for the vaginal adenocarcinoma, the clear cell tumor. It's not an obligate precursor, so if a woman has it, she won't necessarily develop these tumors, but if she has that tumor, she's had adenosis in the DES setting. So all of these conditions, or many of them at any rate, including the adverse birth outcomes, seem to be associated more strongly with DES if the woman has this marker of DES exposure or sensitivity to DES exposure. Next, please. This slide, basically, I don't want to take too much time because some of this probably could go on for a very long time. But there are some structural, you were asking about what it was, there are some structural anomalies too of the cervix that are associated with DES, and these are things that I'm not a clinician, so I've never seen them, so I can't really describe them to you, but the wider transformation zone, the transformation zone is basically from sort of a layperson point of view, and I'm including myself in that category, would be the area between the opening of the cervix and the vagina, and that is wider in a DES-exposed woman, or can be. And it's an area of metaplastic transformation, meaning that the cells there are not exactly the way they're supposed to be. And there are alterations in susceptibility to carcinogenic agents, for example, HPV, and that is one of the concerns with DES, is that maybe the association between DES and that high-grade dysplasia of the cervix is mediated by an increased susceptibility to HPV. Next slide. The prenatal exposure to DES is most infamous in the women who were exposed. The daughters of women who took DES, who were given DES while they were pregnant. And recently, Rebecca Troisi, who is the lieutenant, I guess I would call her, at the National Cancer Institute, who oversees the studies on behalf of Robert Hoover, Dr. Hoover, has published a paper looking at all the different cancers. And Dr. Troisi found an increased risk of the CCA there. That's the clear cell adenocarcinoma that was about 28-fold the normal risk. And this is in this statistic that you're looking at the very top says SIR. That's a standardized incidence ratio. Basically what that means is we are comparing the people, the exposed women in the DES study, to the general population. And we find that age for age, basically, the risk of this tumor is increased 28-fold. That is an incredibly powerful risk in epidemiology. We generally look at risks of 1.3, 1.8, occasionally 2. Smoking and lung cancer, which is one of the most powerful associations we've ever seen, is not even this high. So this is just an amazingly powerful causal association, and it's because of this incredibly strong association that very first study with only 8 exposed cases was able to detect the connection between DES exposure and this tumor. If it had been a lower association, a smaller association, a twofold increase in risk, we might not have been able to, probably wouldn't have been able to detect it in a study that size. The risk of breast cancer that was of initial concern based on a study published a few years back by Dr. Palmer, it appears to be less of an issue. We're not sure that that association is going to hold up over time. I will admit that some of us were a little skeptical of it, and I can't even say why. It's just one of those kind of gut feelings that we would talk about when no one was listening. Sorry. And again, we don't see an increase in endometrial cancer, which is very surprising, given the fact that that's such a sensitive organ to estrogen, but I'm not at all sure that prenatal exposure to DES causes cancer through an estrogenic mechanism. It could be something entirely different that we have not yet identified. And you will see that if you go back up to that CCA, I described to you, I hope, to your satisfaction, what an SIR is. We have two ways of assessing risk in epidemiology, and one is by comparing the risk in our exposed population to the general population, and another is by comparing risk in the exposed population to the unexposed people who are in our study, and that might be a relative risk or a hazard ratio. And if you look across next to that 27.6, you see that little lying on its side 8? That's an infinity sign because there were no cases in the unexposed women. And in fact, it's for that reason that we compare to the larger population, because we can't really compare within the context of our study because there are no cases among the unexposed. Right. Next slide, please. We are concerned about other medical conditions in the prenatally exposed daughters, and they include the conditions shown here. It does appear there might be an increased risk of heart attack, myocardial infarction, coronary artery disease, and possibly diabetes. Does not appear to be an increased risk of stroke or osteoporosis. Why there would be an increased risk of heart attack or coronary artery disease and not stroke is something that I don't really understand. But when we see something like that maybe doesn't sound as consistent as it should, we want to pay careful attention to the data moving forward to make sure that it's not a fluke, because flukes do happen in our research. There's no doubt about it. One of the things that I was asked to look at, which is not exactly my area of expertise because I'm a cancer epidemiologist, was prenatal exposure to DES and what we might call mental illness. There has been a great deal of attention paid to DES in relation to depression, especially in women, and in relation to anorexia in women. The studies of anorexia are not very convincing to me. They're very small. I don't think they were particularly rigorous, methodologically speaking. There was a review of mostly depression in women that looked at previous studies. It was published in 2012. They did not reach firm conclusions because some studies show an association and some don't, which is very frustrating. The Nurses' Health Study, published in 2010, did suggest an increased risk of depression. But there are two caveats with those findings. One is that unlike the NCI study, the exposure to DES is not documented. So people don't really know. And even in studies where the exposure is documented, people don't really know. When we actually ask a woman, were you exposed to DES, or was your grandmother exposed to DES, about 20% will give the wrong answer. They don't really know. So that's one concern. And the other concern is the risk was similar for women who had experienced adverse pregnancy outcomes. So I'm not saying that DES isn't associated with depression. What I'm trying to say is that it may not be a direct biological link. It could be that the experience, the medical experience of women who have dealt with being prenatally exposed to DES is the cause of the depression. So it's an indirect effect, but it doesn't mean it's any less real. Our study, the combined cohort study funded by the NCI, did not show an increased risk of depression in women. The L'Orage study, which was conducted in Paris, does show one, and a great deal of press has been given to that study. I'm very suspicious of their findings. I was on their website about 10 years ago, and they were soliciting membership from people who had been exposed to DES and who suffered from depression or who had suicides in their family. That is not the way to go about a study. And if you want a sound, objective result, that would be sort of like saying, if you have a PhD in epidemiology and you're allergic to eggs, raise your hand, come join our group, and then saying, look at that, epidemiology causes you to be allergic to eggs. I just can't really buy it, and I'm not saying there isn't a link, but I'm not at all receptive to the results produced by that study. So what does DES do? Well, frankly, I don't think we really know. There are teratogenic effects. Obviously, developmental anomalies are a result of prenatal DES exposure. How exactly that happens, toxicity, estrogen, some combination, we don't really know. We do suspect that there are persistent epigenetic changes that are caused by exposure to DES. Not in the mother who is given the DES during pregnancy, but in the offspring. And this is an essential concept to our concern that Sue mentioned about the third generation and the subsequent generations. Because if DES changes the way genes regulate themselves, then this exposure could affect subsequent generations. And once again, the mouse model suggests that maybe it does. In the mice, the third generation mice, there have been studies showing increased prevalence or incidence of tumors of the reproductive organs. That's very concerning. We don't see an increased prevalence of infertility in the mice, which we do see in the women who are exposed prenatally. But we don't see that in the third generation mice. We do see, however, some tumors that are a little bit of concern, obviously, because the mouse model has been so faithful in replicating the human experience or predicting the human experience, depending on which came first. There are several genes that are involved in that are affected by DES exposure, prenatal DES exposure. I want to point out that this is not a direct effect on the DNA. The DNA is not affected as far as we know. It's the way the gene operates that's affected. And the genes that are affected in terms of their regulation are hormone-responsive lactoferrin genes and a series of genes that control the development or the structure or the tissues of the reproductive tract. Next slide, please. So this is basically what I already said. The third generation mice seem to have increased tumors. We're very concerned about this because our previous study of third generation women, the daughters of prenatally exposed women, did show an alarming increase of ovarian cancer risk. I want to point out, because it's very important to keep in mind that this was based on only 3 cases. And it's very difficult to draw conclusions based on 3 cases, but it was definitely disturbing to see 3 cases of ovarian cancer in the exposed granddaughters, especially with the mouse model backing up that finding. We have not seen an increased risk of infertility in the third generation women. The study that I published a few years ago reported that possibility, especially in women over age 30. I'm not really supposed to reveal results that aren't published yet, but I'm going to say that we don't expect to see that again. I hope it won't be replicated. As much as we love the scientific model, the environmental model, we don't want to see human beings affected by this exposure. Enough is enough. So why do we continue to study DES? Okay. The next slide, please. This is the only confirmed human transplacental carcinogen, meaning that the risk actually crosses that placental border. If you know anything about reproductive epidemiology, we talk all the time about crossing the placental border, the barrier, because most things don't, and occasionally a drug does, and then it's a problem for the developing embryo or fetus. And for sure, DES crosses that barrier, and it can cause cancer when it does that. And as far as we know, in human beings, it is the only drug to do that, the only environmental exposure that does that. It also, as I mentioned before, provides a model for potential effects of endocrine disrupting chemicals such as bisphenol A and the phthalates. And we're worried about this because if you don't have that dramatic increase, which is what I was talking about before, you just might not see the association in a study of DES outcomes. We're also worried because the animal studies are remarkably consistent with human findings, so we need to follow the third generation. Even though we've seen some things in the third generation like menstrual irregularity that suggest that DES has had an impact on yet another generation, we won't really be able to nail this down until we get to the fourth generation. And the reason for that is that if a woman is exposed prenatally, when she's still an embryo, her ova, the boilerplate for her ova are already set. And so it's possible that the exposure to DES affected things directly rather than through some epigenetic mechanism. And we don't really know that. But we need to continue to monitor the exposed populations, particularly the granddaughters. It's very near and dear to my heart as we move forward. And I won't be around to do the next generation, but that's, we like to see our studies outlive us. And hopefully we will find that these, the DES effects have stopped with the prenatally exposed generation. I think that would be the best possible outcome we could hope for, because there has certainly it has been a tragic human experience. So the future plans for the NCI DES study include continuing to follow up for breast cancer. We want to try to get a better handle on that, since the association we at first suspected may not be holding up. We also want to continue to look for cervical neoplasia and, of course, for other cancers. One of the things that we're concerned about, and I know that DES women, our daughters, are also concerned about, is the possibility that the increased risk for clear cell adenocarcinoma may return in postmenopausal women. We haven't seen that, and we hope we don't, but we need to keep an eye on it. We are doing some pilot work. We're going to try to look at methylation patterns in DNA. We want to try to nail down how these epigenetic changes might occur. And we want to look at hormone levels and metabolic pathways, not on this slide, but something we're also doing is looking at mammograms to get a sense of whether DES also increases mammographic density, which is a very strong risk factor for breast cancer. And it could possibly, if there is an association between, a causal association between DES and breast cancer, could it be mediated by increased mammographic density? And we want, of course, to follow up the third generation. Regrettably, we don't follow up the sons. We don't have the funding to do that, so we don't know anything about the grandsons except what the mothers tell us. We do ask the mothers to tell us about their sons, because we'd like to know what's going on in the grandsons. But we don't study them directly due to lack of funding, but we will continue to study the granddaughters moving forward. And this is our team. It's a pretty big team. And these are some of my favorite people. I've worked with them now for 25 years. Dr. Robert Hoover heads up epidemiology at the National Cancer Institute. Dr. Cho Isi, who is probably my closest friend, is also working very, very closely with him on the study now. Interestingly enough, Elizabeth Hatch's name isn't on here, Tizzy Hatch, but she preceded Rebecca Cho Isi as Dr. Hoover's lieutenant on the study. She is another very close friend. We've made some wonderful friendships in the process of working through this study. And it may sound like it doesn't matter, but actually I think it does, because we do the very best work we can do. We're working together as a team, and there are no conflicting or competing interests among the investigators. And we're very grateful to the DES Action organization and all the women who petitioned Congress to allow these studies to happen, to appropriate the funding so these studies could happen. And the last slide is the slide for the National Cancer Institute, who allowed all of us to climb on board and get this work done. So thank you.